progressive vaso-occlusive disease involving the terminal portion of the internal carotid arteries or its main branches in the circle of Willis. This leads to characteristic collateral vessels of circulation seen on imaging. These small vessels were originally termed Moyamoya by the Japanese, which roughly translates to puff of smoke. The reported incidence of Moyamoya in the United States is 0.086 per 100,000, which mainly affects people of Asian descent and is less likely to affect African Americans. Moyamoya has a male to female ratio of 1.9 to 1. This disease has a bimodal distribution which peaks around 10 and 40 years of age. Patients commonly present with an ischemic stroke, although patients with Moyamoya have an increased predilection for hemorrhagic conversion due to rupture of thin-walled collateral vessels. Neurologic deficits in patients with Moyamoya are extensive and diverse. Presentation can include, but is not limited to, seizures, headaches, TIA, visual deficits, speech disturbance, intellectual deterioration, cranial nerve palsies, and gait disturbance. We hereby present our 57-year-old African American female who originally presented to our hospital in 2017 with sudden onset left arm and left facial weakness for 4 days. Past medical history was significant for hypertension, COPD, CAD, and congestive heart failure. The patient denied any personal or family history of sickle cell or autoimmune conditions. Stroke pathway was initiated and non-contrast head CT was significant for a right MCA infarct. However, TPA was not initiated because the onset of symptoms was greater than 4.5 hours ago. Labs were drawn including coags, TSH, lipid panel, HbA1c, thrombosis workup, and autoimmune panel. All labs were negative for any acute pathology. A cerebral angiogram was performed and showed extensive atherosclerotic narrowing of both internal carotid arteries. Furthermore, this also revealed collateral reconstitution and attenuation of most of the opercular branches of the right angiographic Sylvian triangle. Diagnostic studies, coupled with clinical presentation, were compatible with a diagnosis of Moyamoya disease. The patient subsequently underwent catheterization of the bilateral internal carotid arteries and was discharged on aspirin, Plavix, and a statin. The patient presented again in 2018 with an ongoing headache and dizziness. Non-contrast head CT was performed and thankfully did not show any progression of the initial ischemic event. Due to ongoing symptomatology, the patient was referred for an evaluation for a possible bypass surgery. Unfortunately, the patient was lost to follow-up and presented again in 2021 with worsening weakness and rhythmic jerking of the left upper extremity. EEG was performed and was negative for any ictal frequencies. Stroke pathway was again initiated and was negative on all counts. Head CT did not show any worsening of the ischemia from 2017. The patient was referred for evaluation of surgical revascularization and was subsequently discharged. Diagnosing Moyamoya disease may be challenging, but should be guided by its stroke-like presentation, underlying pathology, and pathognomonic angiographic studies. The incidence of Moyamoya disease is highest in Japan, but has now been reported in ethnicities all over the world. Current medical management in the acute phase aims to maintain cerebrovascular perfusion. Unfortunately, there is no known medical treatment that is curative or remissive. Surgical revascularization involves temporal or middle meningeal artery to middle cerebral artery bypass. After surgical intervention, symptomatic progression is reduced from 33% to only 2.6%, with the majority of patients remaining stroke-free at the 5-year time mark. This case highlights the importance of considering Moyamoya disease as a differential in a patient with stroke-like symptoms while also highlighting a rare presentation among the African American population.